Okay, picture this. You're in the ED. Maybe it's late, maybe it's crazy busy. Then you hear it. Code stroke. ED entrance. Your pulse quickens. You see the patient. Just moments ago, they were fine, now slumped over, speech slurred, eyes looking way off to one side. There's this energy, right? Weakness on one side, slurred speech. That clock is just screaming at you. It feels like every single second matters. What do you do? What's the very first thing?
Yeah, and what's really striking in moments like that, and it happens every day, right, is just how fast these neurological events happen. The brain, well, it doesn't have much wiggle room, not like other organs.
Right.
So getting it right and getting it right fast, it's not just helpful. It can literally mean the difference between someone walking out and, well, a life changed forever.
Yeah.
This deep dive, it's really about giving you those key insights, the stuff that actually matters, the curls and system.
A system, yeah.
A systematic way to handle these really high stakes situations, whether you're on the wards or, prepping for exams. And remember, the absolute bedrock for any sick patient, especially neuro, is ABCDE. Airway, breathing, circulation, disability, exposure. Always.
Exactly. So today, we're cutting through that noise. We're diving into the big three neurological emergencies: stroke, seizures, and altered mental status. Think of it as your fast track guide, packed with stuff you actually need to know. The goal here is to get you ready to make those quick, life-saving calls. Because like we said, every second counts. It really, really does.
Absolutely.
Okay, so let's start with stroke. That mantra, time is brain. It's not just catchy, it's terrifyingly real.
It really is.
I mean, stroke is a huge cause of disability, death, and the speed. You're losing, almost 2 million neurons a minute in an ischemic stroke if you don't treat it?
It's staggering. Yeah, 1.9 million neurons per minute. It really hammers home the urgency. And, broadly speaking, strokes fall into two buckets. You've got ischemic, that's the blockage, the clot, about 87% of them.
The vast majority.
Right. And then hemorrhagic, which is the bleed. That includes bleeding right into the brain tissue or subarachnoid hemorrhage, SAH. And your first steps in the ED, totally different depending on which one it is. You got to figure that out fast.
So with that urgency, what are the absolute red flags, the symptoms that just scream stroke alert?
Sudden onset, that's the key word. Sudden weakness, numbness, usually one side, face, arm, leg, maybe trouble walking, loss of balance, vision changes like seeing double or, losing vision in one eye.
Okay.
Speech problems too, slurred, garbled, can't get words out or can't understand. And for SAH specifically, that sudden severe thunderclap headache. People often say, worst headache of my life. It hits them like a bolt of lightning.
Right, that thunderclap description is classic. Now, what about those trickier ones? Posterior circulation strokes. They can be subtle. Any pearls for spotting those?
Yeah, that's a great point. Posterior circulation, and brainstem, cerebellum, PPICA strokes, Wallenberg syndrome. They don't always present with that classic one-sided weakness. So for these, remember the deadly Ds. It's a good mnemonic. Dysphagia, trouble swallowing, diplopia, double vision, dysarthria, slurred speech, and dysphonia, hoarseness.
Deadly Ds. Got it.
Often you'll also see weird sensory stuff.
Yeah.
Like loss of pain and temperature on one side of the body, but the opposite side of the face, that crossover pattern. That should make you think posterior circulation, definitely. Okay,
so patient comes in, you suspect stroke, you're looking for these signs. What's the one piece of history that basically dictates everything for acute treatment, like clot busters?
The last known normal time, LKN. It's absolutely paramount. When was the patient last seen completely without symptoms?
Right.
It sounds simple, but it can be really hard to pin down, especially if no one saw it happen or they woke up with symptoms.
Right.
But you have to try, and diagnostically. Your first non-negotiable step is an immediate non-contrast head CT.
Got to rule out the bleed.
Exactly. You absolutely cannot give thrombolytics if there's blood. MRI. Sure, it can show ischemia earlier, maybe within a couple of hours, but it's often just not practical or fast enough in the heat of the moment in the ED. CT first, always.
Okay, CT first. Now, blood pressure. It's not straightforward in stroke, is it? There seem to be different targets depending on the type and if they're getting TPA.
Totally. It's a common area of confusion. So for ischemic stroke, if they're not getting TPA, you actually allow permissive hypertension. Let it run a bit high.
Why is that?
Well, the idea is that higher pressure helps perfuse the area around the clot, the ischemic penumbra. Yeah. So you only really treat if it's super high, like SBP over 220 or diastolic over 120. And even then, you lower it gently, maybe 15% in the first day.
Okay. But if they get TPA?
Then it's different. Strict control. You must get the SBP under 185 and the DBP under 110 before you get the TPA, and then keep it under 180 over 105 for the next 24 hours. Labetalol and nicardipine, those are your go-to.
And for hemorrhagic stroke, like SAH?
For SAH, the goal is usually a bit lower, maybe SBP under 160 to reduce rebleeding risk. But you still need enough pressure to perfuse the brain. And a key point here, avoid drugs like nitroprusside or nitroglycerin in SAH. They can dilate cerebral vessels and actually worsen intracranial pressure. Bad news.
Good, Pearl. Okay, and the big gun for ischemic stroke, TPA, the fibrinolysis, what's the window again? And that other key drug for SAH.
All right, so TPA, alteplase, it's super time sensitive. Generally, the window is within 3 hours of symptom onset, sometimes extended to 4.5 hours in certain patients. But you need to screen carefully for contraindications. High risk, high reward. And for aneurysmal SAH, the big worry after the initial bleed is vasospasm. That narrowing of blood vessels, usually days later, causes more strokes. So you give oral nimodipine. It's a calcium channel blocker specifically used to help prevent that. Really important.
Okay, that's a lot on stroke, but crucial stuff. Let's shift gears. Another neurological emergency that demands speed. Seizures, especially status epilepticus. So the patient rolls in, they're actively seizing. Full tonic-clonic, it's not stopping. What exactly is status epilepticus and why is it so dangerous?
Okay, so status epilepticus, or SE, is basically a seizure that lasts too long, or seizures that happen back-to-back without the person fully recovering consciousness in between. The classic definition now is seizing for more than 5 minutes continuously.
5 minutes, not longer.
Used to be 30 minutes, but we know now that brain injury starts much, much sooner. Prolonged seizures cause excited toxicity. The neurons get overstimulated and start to die. So yeah, more than 5 minutes, that's a medical emergency. It leads to worse outcomes, higher mortality. We need to stop it fast.
And when they're seizing like that, it's chaos. What history is absolutely vital, and what physical signs are you looking for?
Getting a witness account is huge. Was there an aura? Any known triggers like missed meds or maybe alcohol withdrawal? How long did it really last? Did anyone give meds before they got here? You're often flying blind without a witness.
Right.
On exam, obviously the seizure activity itself. But look for clues like urinary incontinence and tongue biting, specifically lateral tongue biting on the side of the tongue. That's pretty strongly associated with generalized tonic-clonic seizures, biting the tip, less specific.
Lateral tongue biting. Okay, so they're seizing. What's the absolute first bedside test you grab? And what are the immediate management steps, even before drugs?
Bedside glucose, always. Mandatory for anyone with altered mental status or seizure-like activity. Hypoglycemia can look exactly like a seizure, and it's so easy to fix.
Good point. Don't miss the glucose.
Never. And then, ABCs. Airway. Are they protecting it? If their GCS is low, like 8 or less, they might need intubation to prevent aspiration. Give oxygen. Protect them from injury. Clear the area, maybe put a nasal trumpet, but don't forcibly restrain them.
Okay, ABCs, check the sugar. Now meds. What's the first drug you're reaching for? And what if you can't get an IV?
Benzodiazepines. That's your first-line immediate treatment. Forvilorazepam is often preferred. It works fast and lasts a decent amount of time. But if you can't get IV access, which happens a lot when someone's seizing...
Yeah, veins are hard to hit.
Exactly. Intramuscular midazolam is just as good. Actually, studies show it's great for pre-hospital use. Paramedics use it all the time. So IV lorazepam or IM midazolam. If the seizure continues after adequate benzo doses, then you move to second-line agents.
Like what?
Things like phenytoin or fosphenytoin, which is easier to give, or levetiracetam. But while you're giving meds, you're also thinking, why are they seizing? Is it low sodium? An infection like meningitis? Did they overdose? You got to find and treat the underlying cause, too. That's often the key to stopping it for good.
Makes sense. Okay, third scenario. Patient arrives, totally unresponsive. GCS maybe 3. This is tough, right? The differential is huge, and a lot of it is bad.
Absolutely. Yeah. Unresponsive patient, GCS 8 or less, generally signals coma. And this is where you need to be systematic but fast. And a really crucial pearl, especially for exams, but also just practice. Never blame unresponsiveness solely on alcohol.
Even if they smell of it.
Even then.
Yes.
Yes, alcohol lowers GCS, but did they also fall and hit their head? Do they have meningitis?
Yeah.
An overdose? Metabolic problems? You have to assume there's something else going on until proven otherwise. Don't get tunnel vision.
Right. Don't anchor on the alcohol. So beyond ABCs, bedside glucose, what's the immediate game plan? What do we give empirically while we investigate?
So airway first, GCS less than or equal to 8 usually means intubation to protect that airway. Then, while you're figuring things out, you give the coma cocktail. It's classic for a reason.
What's in it again?
Dextrose, usually D50W, naloxone for potential opioid overdose, and thiamine. And the key sequence here, always give thiamine before the glucose if you suspect alcoholism or malnutrition. Because giving glucose first in someone who's thiamine deficient can actually precipitate Wernicke's encephalopathy, which is a devastating, potentially irreversible neurological condition. Thiamine first, then glucose. Easy to remember, prevents a catastrophe.
Got it. Thiamine, then glucose. What red flags are we looking for on exam or in those initial tests that point towards something structural, like a bleed or increased pressure?
Look for focal signs, one pupil blown, one side weaker than the other. Signs of head trauma. Check for neutral rigidity, neck stiffness that screams meningitis or maybe SAH. Papilledema, swelling of the optic disc. That's a sign of increased intracranial pressure, ICP, but it's often a late sign.
And Cushing's triad.
Yeah, Cushing's triad, high blood pressure, low heart rate, irregular breathing. That's a very late, very ominous sign of severe ICP and impending brain herniation.
Yeah.
You hope not to see it. Investigatively, after glucose, get that stat non-contrast head CT.
Looking for blood, mass, stroke.
Exactly. Subdural, epidural, SAH, intracerebral hemorrhage, tumor, large stroke. If the CT is normal, but you still strongly suspect meningitis, encephalitis, or maybe SAH, then you consider a lumbar puncture, an LP, but only after the CT has ruled out a mass that could cause herniation with the LP.
Right, CT before LP if you suspect raised ICP. So putting it all together for this unresponsive patient, what's the overall management strategy?
Beyond the coma cocktail and the initial diagnostics, it's detective work. You treat what you find. If you suspect infection, start broad-spectrum antibiotics empirically. Correct severe electrolyte problems, sodium, calcium, magnesium. Manage temperature, cool them if hyperthermic, warm them if hypothermic. Treat agitation carefully. The goal is always to find and reverse that underlying cause as quickly as possible to minimize any permanent brain damage.
Okay. Wow. That's a whirlwind tour through some really high-stakes scenarios. So pulling it all back, thinking about the ED chaos, what's the bottom line? What should people take away from this?
Yeah, if you boil it all down, for navigating these critical moments, whether it's real life or an exam question, I think there are 3 key principles, 3 non-negotiables.
What are they?
1, time is brain. Speed matters in assessment, diagnosis, treatment. 2, always protect the airway. It's fundamental. If they can't breathe, nothing else matters. And 3, never miss the reversible causes.
Simple things first.
Exactly. Glucose, the coma, cocktail components, looking for infection, electrolytes, hit those basics hard.
Yeah.
If you stick to those principles, time is brain, protect the airway, find the reversible degradation, you'll generally do the right thing for your patients.
That's brilliant. And it's so true. These aren't just things to memorize for a test. They're absolutely critical in practice. Every second in these neuro emergencies, it really can mean saving not just a life, but someone's entire future, their ability to function, to connect. So as you head into your next shift or study for that next exam, keep these ideas front and center. This knowledge, it isn't just abstract information, it's power, the power to make a real difference when things are critical.